Hello, everyone. Welcome once again to our remote scanning webinars. For those of you that watched the last two episodes, this third one is a little bit of a shift gear. So we're gonna change completely the narrative. So we were talking about companies and how to introduce remote operations, how to implement them, the advantages, the pitfalls. We had an amazing conversation with Martin. Today we have Zoe Holmes. Zoe is here with us from Australia. I think it's around 5 a.m. there, so I want to thank her for joining us today at such an early hour in the morning. Zoe is a radiographer, and she's doing remote operations on a daily basis. So I think this kind of webinar is going to be extremely important within the whole series, because it's someone that is doing this every single day, and most of us are radiographers, so we can ask all kinds of questions about how her day looks like, in terms of salaries, in terms of staffing, in terms of how many scans she's doing, and all of those things. So really happy to have Zoe with us today. She will put the camera on in a second. Julian, just so you guys know, is a little bit late because he's stuck he's commuting back home. So he will be joining us in a second. And to start, I just want to thank you all for being here today. And please, mics and cameras off, as you already know. We're recording the session. It will be live the whole time today, and then we'll have it on our YouTube channel that will be part of the remote scanning webinar series. So there will be 7 episodes. This is the third one. And Zoe, if you would like to say hi, please, you can put your camera on and mic so people can see you as well. So welcome, Zoe.
Hello, thank you so much for having me, Sam. I really appreciate you taking the time to have me be a part of this. It's such a great venture you're doing, and it's amazing the series that you're putting together. And just, yeah, thank you so much for having me.
Wonderful. No, thank you, because as I was saying to everyone, it's like middle of the night where you are. So it's really an honor that you're taking the time to be here with us today to talk a little bit about something that we all love or hate or want to understand a little bit better. Because I think people on the audience are probably a little bit around the spectrum of loving it or hating it. And there's some people in the middle, of course, that are here to try to understand what it is and how it works. So before we go anywhere else, can you tell us who you are, your career progress? Because I believe you started in not in MR actually, but you ended up in MR. So do you want to tell us a little bit about your progress within the radiology world?
Yeah, absolutely. So I was living in the Northern Territory. So for those who know Australia, Northern Territories usually more rural and remote. And then I went to university in New South Wales. So I used to have to get on free planes to attend university. Once I graduated, my first job was in the public sector. So I was a general radiographer. I did my CT training immediately after I qualified. About 14 months in, I realized, oh, think I want something a little bit more than CT can offer me. When I was a student, I'd done a placement at a more rural hospital, and I had spent a fair bit of time with the MR team for about 2 weeks, and they were sensational. I loved it. I loved the flow. I loved the patient interaction. The machine was so interesting, and we hadn't really covered it at university, but I was like, oh, this is really cool stuff. So then I was qualified. I was looking for the next big thing. I thought, sonography is not for me. And in Australia, you do your undergrad medical radiation science bachelor and go into medical imaging. So I was like, what's my next thing? I really want to chase this MRI training. I think that's where I'm meant to be. So then started phone calling, started looking around, and I jumped about 4 different jobs to chase MRI training down and moved 4 or 5 different times in the next 18 months. And I was passionate. I wanted the MR. I picked up a few extra multimodality skills along the way, cardiac, CT. I worked across multiple vendors. I did mammography. I started a couple of student education programs and got really into teaching and educating, which is something I'm really, really passionate about. And then I went to a private hospital, and they were neuro subspecialty, and that's where I got my MRI training under a fantastic team. And then a year and 2 years later, I then went into private practice, which is where I am currently now with my company. and I was involved in a couple of MR installations, and that's where I got to be involved in protocol development, lots of teaching and educating. And then I've recently moved to the Australian Capital Territory, so ACT down south, and I still get to work with my team up in Queensland that I left behind. And I actually get to work with a couple of other teams now that's starting to expand my role in regional New South Wales. So it's just kind of built from there.
How far is where you live now from where your team used to be at the moment?
So there
Just
in
so people
Queensland, I'm in.
have an idea.
So it's at least one plane, so it's a 2-hour plane flight, and if I was to drive, it would take me about 24 hours.
Crazy.
So,
Okay. So
yeah.
that's where you used to work, and now you basically working at home, as far as I understand. But you still work with the same team, but 24 hours away there you would be if you had to drive there. One of the questions that a lot of people ask us, and it's quite common, does it make sense financially to move to a remote work? Because a lot of the narrative out there is there are going to be cost savings, and the cost saving implies most of the times that the employers are paying less to the remote technologists than to the on-site technologists at the moment. Is that a thing? Is not a thing? We're completely wrong. What's your thoughts on this?
So Australia's very lucky, my company in particular, but we have a very transparent EBA. And no, the guys that are on the ground are not being reduced in their income at all. They're still being paid as if I wasn't there. So my services that I provide, being remote cockpit, I am teaching and educating and I am support. In no way does that take away from the person who's on the ground doing the scanning, the MRI radiographer there. So in terms of remuneration, it is still on par with what they would be getting if I wasn't available.
And
And
on
the
the
beauty
remote
of it is, I was
and
going to say, yeah. So my remuneration, as well as I was an imaging manager when I was up in Queensland, I had 5 sites underneath me. And since moving, my job roles changed a little bit, but I still get remunerated as if I was on the ground as an MR radiographer with the same level of experience that they would expect,
That's
which
awesome.
is
I think a
great.
lot of people will feel a little bit more calmer because there's a lot of banks like, okay, if I'm going to work remotely, probably I'll get paid less, and I don't want that. So I think there's one of the great questions that we wanted to ask you. And before we do that special thing that we were talking about, is how did your life change? Because you, as you were saying, you were managing 5 clinics, and now you changed to kind of a part-time in the hospital, part-time at home, remotely. So how did your life change when you actually went to do this kind of work?
So I actually originally started doing remote cockpitting 3.5 years ago, when the technology was only just emerging in Australia. It was in response to my partner. He has to move for work every 2 years, and we don't always get a choice. So he was in North Queensland, and I was in Brisbane, and I didn't want to leave my amazing job, my amazing team. So something that was really unique was my company said, okay, you can do FIFO. So I was flying in and out of Brisbane to Townsville every week. So I would
Wow.
get on a plane Monday night, I'd fly into Brisbane, I'd be there for 3 days, and I'd fly back Thursday night to be with my partner. And I think it was just really hard at the time because I have spent so much time in MR and I was training people and I had a team. And you really feel like you're letting people down when you have a team and you're thinking, my personal circumstances mean I can't be here every single day, but how do I support you? So when the remote cockpit came out, we thought this is such a fantastic thing. So we got given a license and we started doing it. I would do it 2 days a week, kind of whilst I was away. And it was amazing. I could support my team. I wasn't then so far disattached that I couldn't be there just to help when they needed me or pick up a phone. Most of us MR radiographers and even in extension, other modalities, if we need help, we run out and get a colleague. If you don't have a colleague, you're on the
Awesome.
phone to someone, you're trying to FaceTime someone. How does that help? Like, I can't jump in and be like, oh, like, just change this parameter or have a look here for me and change this. And it isn't always the safest for patients either. So doing that for 2 years, the FIFO and then the support, and now moving into a more official role of remote cockpitting now in Canberra, I think it's been sensational to see the development and the implementation and how staff on the ground have really relished in being able to have someone to contact that can't just be on the phone to help, but can actually see what you're doing and help guide you and things that you might not otherwise pick up. And I don't know about you, but find it's really hard when you have your phone and you're trying to talk to someone and your phone's moving away from the screen, and all of a sudden you can only see like the little corner of the,
Yes.
the scanner or whatever. So at least when I'm in the cockpit, I can guide, I can mentor, and I can guide them on exactly where they're going. Or if they're really struggling, I can help take over and say, okay, we've given you a few seconds to work this out. Let me show you. And they go, oh, that was so easy. Why didn't I think of that? So yeah, I think
There's 2 points there that I would like to touch upon. One of them is you're saying that you can help them, for example, build protocols or actually scanning by giving them tips instead of having the phone, as you were saying. Because, for example, when I talk to my mom, she wants to show something and I'm looking at the ceiling, right? Um,
yes.
I know where you're coming from. So the idea is when you're doing this, you have probably 2 modes of doing it. One is the view mode where you actually just seeing what they're doing and you can talk to them. The other one is basically when you actually take control of the scanner, right? So there's 2 modes, just people understand. And one thing that I want you to explain to or tell everyone is you mentioning remote cockpit. So I think that's because you're using Siemens technology, let's say. I think it's probably why. Yeah. So that's a brand name, so people understand. But there's other names, of course. But if you can just talk a little bit how you jump from, for example, view to control. How do they allow you to do it? Is it a straightforward thing? You have to call them. How is that happening?
So, the way that I perceive it, there's two different types of remote cockpitting slash remote scanning. There's the part that I do, which is quite educational based. I'm a supernumerary, and then there's the more traditional one that's coming out, which is you're scanning for the purposes of being the MR radiographer available, and someone is more of like a patient manager who's MR safety and getting patients on and off the table. So mine is the former where I'm more education, training, and assisting. So I don't use the view mode. I'm jump in and I'm able to take control of the scanner at any point in time. It typically makes it a lot easier for protocol building and development. And then where was I going to go from with there? Can you just repeat the crux of that? Sorry, Sam.
The first one was that exactly that point of jumping from view to remote. And I also forgot the second
Oh,
question. It's a name, the cockpit. Why was the name? Because it's a brand, so that's what we
yes.
was aiming at. So it's a brand thing. That's why you say remote cockpit and you don't say, for example, command center, or you don't say something else. So it just to make clear to everyone when you say cockpit, it comes from the actual platform that you're using. So let's pick up on that platform thing. Are you using more than one scanner, or you just scanning, for example, on that Siemens? Are you scanning in other scanners as well from different manufacturers?
So no other manufacturers as of yet. I know that the other vendors have brought out different platforms as well. I think they're coming more into effect more and more. I just feel like I think Siemens have gotten a bigger platform here in Australia, but I know that like Philips and GE also have very good platforms too, which is great.
I
I was
think
going to round back
they're
that. Oh,
popping up
sorry.
as mushrooms, as I can see now. And not only the OMs, but
Yeah.
private companies as well are developing a lot of platforms, which is good because having that kind of competition makes you actually want to develop a better platform that is easier for you to use and for the patient and for the local technologies. So I think this is the time to show the surprise to everyone because we can actually show
Mm.
how your day looks like, right? So what Zoe did, and I'm really thankful that she did it. She filmed a little bit of her day, so we can all see how Zoe goes about on a day-to-day basis while doing remote scanning. So I'll try to share this video in a second, so everyone can see how it looks. Zoe, I'll go share now. You okay with that? Last chance
Yeah,
to retract
absolutely.
it. Okay, wonderful.
No
All
one judge me, not a social media person.
Can you all see the beginning of the video? Is it good? Yeah, okay.
Welcome to a day in my life as a remote cockpit MRI radiographer. I thought I would give you a quick tour of the department I now remote in for. So my day starts with an early morning wake up to hit the gym with my husband. Gotta make sure I bring the essentials headphones. caffeine, and lots of water. After a quick walk to the gym and a session later, it is time to head back home and get ready for a busy day ahead. Today's list of jobs includes building some new protocols for patients who present in casts, teaching the on-site MRI radiographer some tips and tricks for protocol development and adaptation, checking referrals to be booked across 2 sites, and double-check all the MRI booked for the week ahead to ensure everything is correct. I cannot go far without another coffee, and appreciating the great views Canberra has to offer. Once in the home office, it's time to log in and say hi to the team on site. Currently, we are building an ultra-fast ankle protocol to support our pediatric and patients who may struggle to remain still during a conventional scanning time. I'll be here working through my list and offering support and training to multiple sites during my day. Thank you for tagging along.
Thank you very much. I think that's awesome. So we have a little bit of an overview of your day. And I think a lot of people ask themselves, how is it to be a remote technologist? Because a lot of people feel the stress that they have to be glued to the computer 24/7 and they can't take their eyes off it. But tell us a little bit about this video, how your day goes normally.
So I'm very, very lucky. So just so everyone knows, the patient on the scanner was one of my staff as well. We did not record a random patient on the machine. So usually when I'm doing a remote day, it'll be with a particular MR radiographer. So I work with 3 to 4 different staff in that particular site, and each one has different goals they want to achieve. So more of the advanced MR rads want to do protocol building and development. They want to try and manipulate scans. They want to understand the actual crux of the scanner a lot more. So when I'm on with those guys, we prioritize harder scan types, providing services and different MRs that maybe we wouldn't have been able to perform if I wasn't available to help. Things like we do a lot of peripheral angiography, popliteal entrapment and stuff like that, or Meniere's diseases and building protocols for those. So when I'm working with those techs, I'm prioritizing more advanced scans. I protocol for 2 sites up in Queensland, all the MR referrals that come through. So if there's ones that come through that are more complex, I can say, can you please book it on a me day when I'm available, so that that tech can get more experience at something more advanced they might not have otherwise ever seen before. And then when I'm working with my more junior MRI radiographers who maybe want to focus on efficiency, flow, understanding pathology, do they need that extra sequence, and more safety-based stuff, then I can change gears and I can be that kind of support to provide for them. Currently, I'm predominantly just working with the one MR up in Queensland, the one at Ipswich, but I've had to unfortunately drive 3.5 hours to a regional area in New South Wales and spend 2 days with the team at this site to be able to help them build their protocols, because they wanted faster scans, they wanted more quality, and they're like, we just don't know how to do that. We didn't get a lot of application specialist time when our install happened. So I ended up driving at the crux of dawn to get there to start their MR lesson, and I drove back on the Friday after theirs, and I didn't get back till about 8 o'clock. But if I had the cockpit set up or the remote scanning capabilities, I would have been able to just log in and spend 2 days with them without spending like 6-7 hours in the car to be able to provide that. So I think the value is amazing and really there. And we'll do small lists and big lists. I think the most we've done in a day is 26 MRs back to back. And the smallest amount would be 9, but it just depends on the day and the types of scans that we're getting. So it gets tailored, I feel, and the support that I can provide is quite tailored, which is nice.
And it sounds very flexible, right? So you have different things to do in different days, and the job is never boring, from what I understand. Diogo on the audience is asking a question actually that we can just pin straight away, which is the fact that you're doing your own protocols, and he's asking if you don't have to check with the medical staff there, with the radiologist, if you have that autonomy in Australia, according to your laws, to actually do those protocols. Is that something that probably differs from where we live and work?
Yeah, we're very lucky. So we can play with sequences as we go. So if every month, what I'll get my staff to do in particular, I'll ask them, hey, I want you to build me a new axial PD fat suppressed one for the knee. Currently, it's this time and this slice thickness and this resolution. I want you to make it faster. I want you to make it thinner slices. So we actually play a bit of a game of who can make the best sequence for that month as we are continuously having a play with the protocols, because otherwise, how are you ever meant to learn? And that was something that was hard for me when I was learning. No one ever taught me how to make protocols. So when I inherited a site that had a MR scanner that the two hip protocols were not the same sequences, I thought, how do I fix this? I've never built protocols. So I would come in on my weekends, and I remember I had bought, you're not meant to scan, you can't scan patients all the time. So I bought a ham on a bone, and I scanned this ham on the bone for 2 hours on the weekend, trying to understand how to build these protocols so then I could develop it further on site. And that's kind of the extent I had to go to. I can't imagine it for someone else who might not feel as comfortable or have a supporting environment that says, yes, you can come in on the weekend and stuff. So, yeah, in Australia, from what I understand, the radiologists don't mind if you have a play and build an extra sequence. As long as you have the original sequence there for them, you can grab another one from the library or play with the one that you currently have to see if you can improve it. And how else are you meant to learn other than playing and adapting and seeing what does and doesn't work to really understand the crux of protocol design?
Yes.
Yeah.
Julian joined us a while ago, but I'm just me and him, we share this kind of understanding of education that it needs to be hands-on. Because most of the times what we have is one lecture, or you have one PDF here or a tiny book, and we like to do these kind of things like podcasts and videos and webinars, because for us it's more hands-on thing that we can learn, and from experiences like yours. And you touched upon a few things, just for those that came in later. You touched upon the salary that doesn't change that much. We touched upon the fact that your change to work from home was gradual, and you actually enjoy doing it because you keep in touch with the staff that you were working before as well. And you also mentioned the fact that in Australia, as we all know, is a massive country, and there's a lot of rural areas that don't have access to this kind of technology, right? And you have to drive 3.5 hours or more to go and help someone develop the protocol or scan a patient, something like that. I know you have a very personal story to share with us, and I would love if you would be able to share that story with us to show everyone how important a remote operation can be at the personal level, at the family level, when it's the ones that you love the most that need it and we don't have it. So if you don't mind to share that story with us, I would really appreciate it.
Yeah, no, and I think that's really beautifully put. Something that I talk about a fair bit is a lot of fear and hesitation that comes from things like remote scanning and remote operations, comes from the fear of what's the worst thing that can happen. But people often forget that in metropolitan areas, you're making these decisions, but you actually haven't seen what it's like out in these rural areas. So where I did all my high schooling and my gap year, I lived in a town with 3,000 people. We used to get our food on a barge. And if we had a cyclone or a weather event, God forbid you needed bread for the next 2 weeks. And the land was inaccessible for 6 months of the year. We only had 2 seasons. We had a hot and a wet. And when it was wet, you couldn't get out. So my dad works in mining, and he suffered a workplace injury where he had bulging discs in his lumbar spine that would quite literally incapacitate him. There were times when I had to drive him to the hospital and he couldn't sit in a chair. He'd have to lie flat in the back of the tray of a four-wheel drive because he just couldn't physically sit because the pain caused with the sciatica. We don't have a CT scanner in where I was in Nhulunbuy. So there was only X-ray and ultrasound. So for my dad to even get an MRI, which is the gold standard for disc assessment, he had to get on a plane. So we would have to get him medicated, get him to the airport, get him through security, get him onto this plane, and then get him to be able to stay still for 2 hours as we flew to the next closest capital city or the largest area that had access to a CT and an MR. You'd fly out in the morning, you'd get there, you'd then have to get to the neurologist's office or the person that you were seeing, get your scans done. And if you needed an interventional procedure, you just hope that they'd saved a spot for you. And I think it just really drove home. We had to do this multiple times to be able to get him any sort of diagnostic imaging. It wasn't even just an interventional procedure. So it really highlights to me that the inaccessibility of these advanced modalities in rural and remote areas is really, really hard. And I hear stories at the moment. There is another company in Australia who's trying to facilitate additional scans and reduce the need for people to have to travel extended periods of time, take days or a week off work to be able to just to get an MR by doing this remote scanning. And they're doing it to try to help the population. I honestly really believe in my heart, if you asked a patient, would you be comfortable with having a remote scan done or a remote cockpitting? Like I'm there in the background with a more junior MRI radiographer who's safety trained to perform your scan if we can do it more locally without the need to travel. I'm very certain, and I think I know this. A lot of people would say yes, and they jump at it. They're like, if I don't have to get on a plane just to get my MRI scan, or if I don't have to take a week off work, or if my partner doesn't have to drive me 5 hours to the next closest scanner and I can get it done, I would absolutely do it. And I think seeing my dad go through what he did for years and years and years, it would have been amazing to have something closer that could have facilitated a better point of care and accessibility. So I think it's really important that people take away from just saying, okay, we're scared of it, we don't really understand it, and we're not really prepared to say, well, actually, let's think about the people who are rural and remote who don't have the accessibility that we're so lucky to have in metropolitan areas. So I think that's really close to home for me and is a very big driving factor of why I'm so pro innovation and why I love everything that's coming with remote scanning and what it does have to offer. So, and why I love what you and Julian are doing in opening this up and making it accessible to other people to see that it's not a scary thing and this really is starting to pave the way for the future. So
Yeah, I think it's a touching story for sure. And one of the things that people ask me when I talk about this rural thing, when you have, it's like if they don't have MRI, how do they do the remote scanning? There's different solutions, of course. Sometimes they have the MRI, they don't have the skills. Let's put it that way. Sometimes they don't have the MRI, but there's mobile units. There's lots of situations that we can. For example, in UK, we have mobile units all across the country, the countries in UK. And we have centers that are specialized, for example, in cardiac, centers that are specialized in neuro. But for example, if you have someone that needs a cardiac, but that area doesn't have it, you can jump on that scanner where they normally do neuro and have someone remotely access it and do the cardiac for you. So I think it's your story shows exactly why the benefits are not just cost saving, are not just a shortage of staff. It's also about education, also about the fact that you make this technology available for those that don't have access to it on the daily basis. So I think it's really important that you have that testimonial today. And thank you for sharing that story, because I know it's personal, but it's for the good of the community. So I thank you so much for that as well. Julian, do you want to say anything? At least hi to everyone.
Well, I have thousands of things to say. First thing, I apologize for the little delay. This is London, unfortunately. Uh, but yeah, so it's a pleasure to meet you. And actually, thank you. I want to thank you as well for sharing this story, which sounded very personal, but obviously it allowing us to understand a little bit better, as we're saying, also why we're doing this type of like webinar series, in order to understand that there are different realities. For someone might be even more beneficial than others. As it's not like a unique line. We need to consider different factors, different realities. So that's it. And from what you told from the very beginning, I listened to the entire conversation. I can feel the same passion that we have about MRI on everything you're doing, essentially. Everything you're doing on a daily basis, I can literally feel the passion that you have. And this is fantastic because you are transferring this. So I just have a very quick question. I was chatting with one of my friends on the background the other day. He was telling me, yes, but this remote scanning, he was talking about the economical side of thing. And he was like, okay, but how is my life going to change in terms of scanning patient? How many patients am I going to scan differently from working on site? You already mentioned some numbers, but I want to ask you your experience. Like as a remote operator, do you actually have to scan way more patients as it used to be before on site, according to your experience?
no, so there is no company push to increase numbers or anything like that. And it purely so we for my sites, I found it was easier to create a booking matrix based on the experience of the MRI radiographers who are the primary scanners of that day. So similar to, I guess we see in the sonography population, a sonographer will have a skill list. My MRI radiographers have the same thing because everyone's at different experience levels, and that's something beautiful about the MR remote scanning is you can upskill people's skill lists by being there to support and give confidence and help guide them. But until they're comfortable doing it themselves, it doesn't go on their skill list. So we book the scanner as per the person who's on the console scanning skill list and what they want to build and develop and go from there. So what scans they want to learn, we'll book it on their particular day, give them time allowances. But the company has never pushed for, please do increase numbers. And I think the idea of having remote scanning just to increase the numerical value of the scans that you're completing for revenue purposes isn't, I think, the real intention of remote scanning. I think remote scanning was kind of always developed to help bring accessibility of MRs and coverage to rural areas. I know that there's a site rurally that can't get an MR radiographer one day a fortnight. The radiographers only work, the MR rads work part-time. So that whole day, they have a whole day of not scanning, but they have a backlist of 3 months. So it's more not increasing the number of scans that you're doing, but facilitating a service that otherwise wouldn't exist if you didn't have remote scanning or the assistance available.
That's fantastic. I think this will kind of like shed light a little bit on the number of scans performed remotely, which I think was already one of the concerns from people. We had a discussion with Tobias Gilk, I think, in one of our podcast session, and transparently he mentioned that in some settings there might be the expectation to operate 3 or potentially even 4 scanners at times at the same times. So I think maybe this is where also it kind of like trigger a little bit the anxiety, having like to perform multiple scans from multiple scanners at the same time. So I think that might be a little bit the idea behind it. But yeah, thank you for your explanation. Sam, anything
No,
else
that's
to add?
Well, not really. I think you guys covered it up pretty much what we needed to say about that topic. The only thing I can ask now, we have a list, of course, but the question that popped to my mind, and it's kind of a little bit related, is what are the benefits for your patients and for your local staff that you are at home, mainly for your patients? Because as Julian's saying, if you feel the pressure, in some countries, we feel the pressure to do 3 or 4. That happens. Maybe you're lucky that you're hiring a company that doesn't push you to do that, right? But what is the patient's feelings if you're scanning them like an assembly line, like you're just putting them through the machine and take them out? Do you actually tell your patients it's remote? You don't tell your patients? What is the biggest benefit for them that you're actually working from home?
So I think there's a good point to delineate. So remote scanning, like in the most traditional sense, is I'm scanning and then the person on the scanner itself who's doing the patient management can't scan, which is not what kind of I do. The role that I have is the training and education and the supernumerary component. So the person on site can do it all without me. They don't actually need me to run their list. I just provide the confidence building and the troubleshooting component. But I think if you were doing a traditional remote scanning, like there's only one centre currently in Australia who does the traditional remote scanning. And from what I believe, they inform the patient before booking that the person's a remote operator, but they have a MR safety trained. We have a governing body RANSCAR that determines that we need a level 2 MR safety personnel on site at all time. So we do, from my understanding, they do inform the patient that you're booking in a time where we have a remote scanner operator operating out of such and such a location, and the person who'll be getting you ready is a MR safety trained individual whose specialisation is patient safety. So I think just that delineation, I saw a couple of questions pop up, and I just want to make that nice and clear that my job the show would go on without me. It might just be limited. We might not be able to do as many advanced scans as we do, or maybe that we would have more recalls because maybe the staff on site might not have gotten everything the radiologist needed and that kind of thing. But I think from a staff point of view, the services that I provide and the way that we're using the remote scanning, I'm there to build confidence. I'm there to empower the staff to be able to do the absolute best they can for our patients. If there is an artifact that's popping up, I can help them navigate it so that we're not getting the patient off the scanner going, oh my gosh, what is this thing, and scratching our head or trying to navigate it and making errors again and again. So I feel like it helps speed up the patient experience because we're not repeating things unnecessary or wasting time trying to figure out and solve the solution. And when we have a curly scan and we have to build, let's say, the sequences as we go, we're not spending 15 minutes umming and ahhing and going, nope, we've seen this before, this is what we're going to do. And I kind of provide a quicker and faster decision-making process for the person on the ground who might not have that confidence or that assurance in themselves that they can do that. I think for patients, the remote scanning is an extra level of safety. How often is it that you would have an extra MR radiographer hovering in the background to ask MRI safety questions to? And I'm studying at the moment, I've done the MR safety components through the university that I'm going through. Not as many people go through the tertiary centre route with their MR. So I've got that extra level of understanding along with going to conferences and being very pro MR safety. I think it's just, I can have a look over the safety information. An example of that is if we have a patient who comes and let's say they've had a PFO closure, they haven't disclosed that prior to their booking. They're there half an hour early. The MR radiographer's like, oh my God, how do I find this information? I can be like, hey, look, you go do the patient stuff. You just get me the make and model and the information. I will find you the safety information in the background and I will speed this whole process up instead of us needing to rebook this patient. So it's just that
That's an
extra
amazing
level.
point. That's an amazing
Yeah.
point because
Yeah.
one of the things that we spoke last week with Martin, and I know he's listening as well. Martin is doing the scans, right? And you supporting role, you're in a supporting educational role. So there's a myriad of things that you can do with remote operations, and people think it's just you scan from home and that's it. But you can actually be scanning from home, you can educate someone, you can be the backup for safety, you can just build protocols, you can be so many other things at the same time. And I think that's the beauty of this as well. And one of the things they are saying also on the text message, on the messages, is the fact that it's hard to understand what you're talking about when, for example, me and Julian, we have MRIs in every corner. Julian probably got out of his job today and just passed through 3 or 4 hospitals with MRs, and they have probably 5 or 7 scanners.
Well, I need to correct you, Sam. In the area where I work today, there are 42 providers of MRI scanning. So it's clearly that there are parts of the world where there is probably an excess of providers and others that probably should be a little bit more compensated. But anyway, I have to say, guys, from someone that is, I mean, not as involved as you are on remote scanning, but partially involved, I have to say these are the best workflows, ways of utilizing remote scanning you have described so far, because I think this is fantastic. It opens completely a new chapter in my mind, the fact it can be used from an educational point of view, and the safety point of view. So it's fantastic. We had this discussion, but I think the way you ported also the examples, I think it makes it much more clear, and it gives a new perspective about remote scanning. And speaking about that, I have to say there was something mentioned from Anton about the fact of working remotely from another country, but in Australia. And I want to introduce this question with and sort of like an anecdote that Sam knows me now for quite a few years, but I don't think he's aware of this. My original plan before moving from Italy to London was actually to go to Australia. And I was like, wow, it must be amazing working in Australia. I was thinking way better weather, much closer to Italy. So I was thinking, yeah, that's my destination. But I had to kind of like fight back with some complex assessment regarding the qualification, very strict standards. So I reached the point I was like, okay, Australia doesn't want me. It is very difficult to work as a radiographer, So, question, because of these standards, and I do understand that it's difficult to match the same standards that you have in Australia in terms of qualification. You have this body AFRA, correct me if I'm wrong, and they have quite, rigid standards of, criteria. So how do you see the possibility for someone like in Germany, like Anton, like Martin, or for someone in Europe, someone in the US, the possibility to work in Australia? Do you think there will be other channels in the future? Do you think is a possibility at present? Have you heard about anyone doing it?
So it's funny because this is very parallel to things like telesurgery. There was an Italian surgeon who performed a complete prostate removal for a man in Shanghai. So it's the question is, can you do subcontinent work and stuff like that, and remote operations that have the scope to bring specialists in who might be super, let's say, for example, I have a specific vendor machine and I really want to learn or perform like a special type of cardiac imaging, or we're doing Parkinson's study and we're doing the swallowtail sign on a susceptibility weighted image, but no one in Australia is doing that kind of thing. But someone in Germany has done a research proposal on the same magnet that I have, and I would love to get my hands on that sequence, but I don't really know how to apply that sequence or how I'm meant to scan it or how I troubleshoot it. It would be a similar application, I think, to what app specialists do currently. App specialists and engineers can remote into our scanners as it is. What we're doing isn't anything new. This has been happening for years, and no one gets worried about an application specialist jumping onto your scanner to have a look. So why couldn't we, in theory, subcontract a subspecialty MRI radiographer with a passion for Parkinson's, who could subcontract to my company, and they provide on-hands training from Germany, from Italy, their home origin, and their purpose is to build up our services so that we're providing the best possible scans and pioneering advancements in Parkinson's detection. So I feel like there could be scope for those kinds of things, but I think probably more on an international level, we all probably have to get on the same page. I think Australia is quite in the infancy of remote scanning. I think I'm one of, and I only know of 3 companies, if that are doing very limited. I think I'm the only one in my company who is doing this kind of thing at the moment. And I know another company only has 2 sites I think they're doing it for, and another one that has mentioned it, but I haven't seen any evidence of them actually actively doing it. So I think maybe we're just a little bit too young yet, but I think we will start seeing legislative and policy changes. I know that APRA and ASMA, I believe, are making position statements on remote scanning in the foreseeable future. Currently, we're dictated by RANZCAR, but they haven't noted remote scanning just yet. So I think we're just a little bit like Australia is itself. We're just a little bit too young to be fully across it all. But I think there's scope for it. And it would be fantastic, like I said, application specialists do it and they can do it remotely from anywhere in the world. It literally is, the technology allows us to come in with a code. So all you have to do is contact the site, you link up the code, and then you can come in and, it's just about knowledge sharing.
So I think there's a big problem there that I agree with everything you said. And you are 3 companies ahead of Portugal and Italy, I believe, because we have
At least 3, at least.
The main problem with cross-country and cross-continent scanning is certification. Because when you say app specialists, they can actually do it, and they do it. For example, United Imaging, they didn't have any engineers in Europe when they just came. So they had one scanner. They have, for example, to get engineers from China, they would log in and do that remotely. That's fine. They're not dealing with patients. And that's where all this complication comes into place. Because when you're dealing with patients and medical devices, you have to go through the loops. You have to go through FDA, CE mark, UK, CA. You have to go through all of those certifications. And then the bigger problem is my degree in Portugal might not match your degree in Australia. And if we don't have those hours, if we don't have that same education, I'm going to be barred straight away. I won't be able to actually even get a license to work. And I think that's the main problem at the moment, to allow people to cross-country scan, because myself and Julian, we're trying these projects where we will get people scanning from one country to the other, but involves learning the language, first of all, because languages are different. We have to have that in mind. And then, of course, the certification. We will have a degree, for example, my degree in the United States, even if there are some people saying can easily get a license, is not that easy. For example, if I want to go to the United States, I have to do a lot of paperwork. I have to prove them that my degree is actually at the level that they wish it to be. And I had friends, for example, that moved to States, and they had to do 2 years of MR there to be able to have the license, and they were working in MR for 10 years in London. So I think those are the barriers that we're facing at the moment to do cross-country scanning. Those are the biggest ones. But I agree with you. I think this will change. And at the end of the year, there will be news from ABMRS, and things will change. Things will change, and this is the year we're having a lot of momentum, and I think this is the year of capitulation, and for sure things will change in the short period of time. That's my opinion.
I was going to say, it's very interesting with certification, because in Australia, to be an MRI radiographer, it's on-the-job training. So you do not have to hold any additional licenses. You do not have to have any additional certification to be an MRI radiographer, which is something that has really been highlighted, especially through remote scanning, just that Australia actually doesn't have any safety courses that are recognised or promoted.
You shouldn't say that, because Julian might leave to Australia, then I don't have a co-founder.
This is what I was thinking. No, everything MRI, if Australia regulation would have been so strict otherwise.
No, but please
And
tell us about the safety guidelines. That was one of the questions that we wanted to talk to you about, because apparently there's nothing there that is robust and people can follow. So if you can tell us a little bit about that in conjunction to remote scanning.
Yeah, so to be able to come over internationally, it's more the undergraduate degree being recognised and doing a supervised practice program to show that you can do the radiography component. But for MR in particular, if you ever look at any of the job advertisements or you talk to any recruitment agency, typically what they want you to do is have a level 1 ASMET accreditation, which is a 300 multiple choice exam. You have to get 70% or over. But this doesn't just cover safety, it's very broad, the 300 questions, and I would like to see the exam updated or an additional subsection put in that is a certification for safety, because RANSCAR discusses being a level 1 and 2 safety trained personnel, but you don't have to prove that in any way, shape or form in Australia. I'm not sure what it's like for you and Julian, but for us, you can do MRI and you can practice in MR your whole career, and you don't actually have to have achieved any additional than your undergraduate for medical imaging. So, which it's interesting, because I know that other, I think America in particular, if you want to be an MRI radiographer, you've got to go through a program that is structured. And I think maybe this is where, yeah, some hesitation comes in about remote scanning and safety in Australia, is because we don't have these really robust and recognised certifications for MR or for MR safety. It's kind of do what you will. And I remember going to a conference last year
Just to
and
reassure you, sorry to interrupt you. Someone just ran like a poll asking how many hours of MR safety training like most people received, and despite having all the qualification in the world, the answer was like very minimum, to be honest. So I think it's a more like a general problem. There is a lack of MR safety worldwide, and this is what we are trying to acting at the moment with Samuel a little bit in the background, because I do agree with you. So sorry, please carry on. But yeah, just to let you know, you're not alone in this battle. I think the entire world is fighting against a mass
70%.
safety problem. Yeah.
70% of the people said they have none to pretty much nothing in terms of MRI safety education throughout their degree. So, yeah.
yeah. And see, so the RANSCAR guidelines is 3 months full-time, 6 months part-time training. Doesn't actually specify. It says, you should know about RF coils, you should know about these different things to be deemed a level 1 or a level 2 MR safety trained, but there's no tangible way to determine that. There's no courses, there's no nothing to say that you actually understand these things that has been listed. So I think that's a deficiency in Australia that would do really well to be reviewed and reflected on, because like I said, you can be a 10-year qualified MRI radiographer and never done more than your medical imaging degree. And as I was saying, like there's conferences that come out that are, MR safety, understanding MR safety. And I remember the presenter saying, if it's a inactive implant, don't even worry about safety checking it. And I'm like, that's all well and good, but we can't do that, because if something does go wrong, we have the primary and principal responsibility to that patient. You need to be checking these things just for covering yourself as well. There was an incident, like we all have MR safety incidences that happen all over the world, but you hear about these horror stories of patients having implanted devices and stuff, active or non-active, that don't get disclosed, and then something does go wrong in the scanner. And I just think that we don't have the safety certification and training in Australia. And I think, if anything, remote scanning operations, if you're using a patient manager on site who's not an MRI radiographer, there needs to be something for people to train. And I know that a lot of MR radiographers have a lot of anxiety around safety, and that's why my role is fantastic, because I am an extra person to check MR safety, and I'm here at a computer. I've got extra computers set up in the background. As you can see, I can have the remote scanning on one screen, and I can be checking all the MR safety. I can be scrolling through the patient's previous scans. I can be finding them from other companies to make sure that person is safe before they get put on the scanner. But not everyone has that luxury of having a remote scanning radiographer sitting in the background waiting to just jump on and help with all the MR safety information and MR safety situations. And I think, it'd be nice to see more MR safety coming out in certifications and qualifications, or the recognition that a remote scanner operator like myself in a cockpit situation where I think of it as a cockpit, you see two pilots in the cockpit. I'm that second one, that's how I like to think of my job role.
Yeah,
Yeah, absolutely.
Yeah.
And I have to say,
And
to be honest, you mention it. You kind of like call it as a luxury. However, I think, to be honest, it is something we actually really need. And I think this perfectly connects to one of the questions from Abraham. He was asking, from your experience, would you be happy to work with a radiologist assistant on site, or prefer only an MR radiographer? But if you have someone like you that can help the team, to be honest, with your expertise of MR safety, you can either both. You can help an MR radiographer. You could help a radiology assistant as well, which has been previously MR trained, maybe for any doubts. So when you have someone in charge, like a supervisor like you, I think this type of problem, it's good to have this type of conversations. But everything, all these concerns are a little bit less, impactful in a way.
yeah, I think, and especially like having an MIA, like a medical imaging assistant who's getting patient on and off the scanner, like I'm not doing that in my role, but I feel like people will feel more comfortable with the idea if we had really robust MRI safety pathways. But because we don't, there's that fear associated with it. But also, if you were hiring someone as a medical imaging assistant, let's say they're a radiographer who wants to do MRI eventually, but we just don't have capacity to train them yet, but they're willing to go out and, let's say, get certified as an MRI safety level 2 personnel through this gateway or pathway, and they're certified, and their job then is MR safety. So I'm juggling safety, protocol design, scanning, supporting my team. But if that person on the ground is trained and their specific training is MRI safety, they really should be the specialist in that field. So you could almost create a hyper specialized role really for someone who has either a radiographer who maybe wants to do MR later or doesn't want to do all of it, or you could also have someone who's done an undergrad, like we have sonography assistants and stuff like that. We have other subspecialties of allied health. Maybe this could be a thing where you become like a MRI safety certified personnel through, you do an undergrad of, I don't know, biomedical science, and then you go on to get certified as like MR safety specialist, and then you can work as that person on the ground. Like there's so many different avenues, I guess, that we could spitball. But yeah, I just don't know if Australia's there yet.
Well, that's something I mentioned this before, but I'll mention it again, that it's coming at the end of the year, and that's going to be dedicated training for the local operator. And those operators will be called MRI safety technologists. So we'll have people dedicated just for that. There will be 100% patient care, 100% safety. So that's something that is going to be a reality, and it's not going to be a United States thing. It's going to be a worldwide thing. So just so everyone is aware, it's coming. It's just a matter of time, and it's going to be at the end of the year. But to pile up on this conversation, I wanted to understand one thing. Have you ever had an incident while remote scanning from home where you felt like powerless, like I can't help them? I would love to help them, but I can't. If you didn't, how do you think that would go about if you ever had one of those situations?
So I guess for me, we're really lucky that my staff on site are trained. So they are meeting the requirements to be deemed MRI radiographers as per RANSCA. And we do talk through situations. What happens if we had a patient who had a cardiac arrest? How would we respond? those kinds of things. I guess I haven't had an incident yet where there's something that's happened and I've been sitting there in the background thinking, oh my gosh, like I can't help. There's something going on and I can't help. But the benefit is, like, we have the MRI radiographer on site. A lot of my staff are dual trained. They'll do CT and MRI. So there's usually a second or third MRI radiographer within the department. And that's how we have it set up, just for safety reasons, that if we do need to do an emergency transfer out of the magnet to be able to do defibrillation or crash cart, we can get the patient out of the room. We've got more than just one set of hands available. But I think the benefit is, if something's happening, I can call 000. So as part of our safety protocols within our department, we are a clinic. So we don't have the luxury of having a resus team available. And the way that we do our safety training is who's going to be calling 000, 911, and the emergency services, who's going to be recording in the background the medications given and stuff like that in an emergency situation. So although I can't do anything of a physical assistance, my remote presence and being there in the background, I can actually help in an emergency situation, even though it's not the extent that I'd like to. Working as an on-site radiographer, I've had anaphylactic reactions. I've had a couple of patients pass away in a CT setting due to just being in an emergency situation in a deteriorating setting. But I can still assist. I think maybe it's just taking away what can I do as opposed to what can't I do.
Yeah, I agree
From
with you.
emergency situations.
Remote, you can do a lot actually. You can call third parties, for example, fire departments, ambulances, police. You can do all of that. You can contact management teams. You can contact nursing teams. You can do the tracking of the actions for later audits. So there's a lot of things that you can do on the background. Julian, do you want to add a few any other questions? I have one more question, and then probably would, if Julian has one more, that's fine. Probably would jump to the audience questions, because there's
Yeah, exactly. No, feel free to ask your question. I can see that already plenty of question for you, though. So I think you managed to go straight to the point.
perfect.
And people feels like you're very relatable. So I think they can kind of like ask whatever comes in their mind. I might have a lot of questions too, but I will pass it for another time. So Sam, go ahead.
Now, my last question is basic. You should be the one asking this question, actually. You are the AI guy. So I wanted to understand, Zoe, how do you feel like remote scanning is fitting on this broader trend of digitization and medical imaging with AI tools? Do you think is another complement for what's coming? Do you think we're going to completely change the way we do things? I like to believe that MRI, CT, X-ray will eventually merge it one thing. And I know Anthony is here, he will agree with me. And the patient just goes in, gets the scan done, gets out with the results on their pocket. How do you see remote operations with AI and digitization in this moment?
I don't feel like it's going to take the role away from what we're conventionally doing. I think it's going to, the way that I like to do it, I think with all great power comes great responsibility. But I really feel like
this is
is
Spider-Man, no? This is Spider-Man quote. Amazing. Well done.
But I truly believe that this is another step and another enhancing property. This is linking specialists together. This is enabling information sharing. This is about empowering our staff to be able to make better decisions for our patients and to give patients the best scan possible, the best services possible, the best safety possible. I don't feel like this is going to revolutionize to the point where we'll click a button, the patient will just roll through an MRI full-bodied and straight into the CT scanner, then get a full-body X-ray, and then they come off the conveyor belt and everything's there for them to pick up on a USB and head off. I still feel like
No, it's good.
Fingers crossed.
That people have different perspectives, of course. For the sake of our profession, I hope it never happens. But in terms of the way
I'm touching wood at the moment. All the wood that I can feel, I'm touching everything.
Actually, I will ask Anton to jump in if he wants, because he also has an opinion on this thing. But please continue, Zoe. Sorry to interrupt you.
That's okay. But no, I feel like this is just an extension of technology that's coming out and developing. You know, when the first PR plate came out for X-ray, everyone would have gone, "Oh my God, there's voodoo! Like, what happens if it disconnects? There's no physical link. I'm not holding on to something anymore." There's always apprehension when it comes to a new technology emerging and a new advancement. And, now down the line having DR plates, I don't think we even have film left in Australia anymore, and CR is slowly getting filtered out as well. I think it's just going to be a natural progression, but I really feel like it's going to be an enhancement of services. I foresee this technology allowing better intercommunication between people with lots of experience, such as myself, being able to help more junior MR radiographers. It's about creating better scanners. Like, we can create protocols that are faster, thinner slices, better resolution, better to cater for the indicators the patient is having, and being able to provide a more tailored and specialized service to them. So I really feel like it's just going to become an extension of all the goals and values that we have in MRI. And the way that I see it from a training education and the cockpitting component of being there and holding an MRI radiographer's like theoretical hand is that this is about enhancing knowledge, sharing knowledge, and being at the forefront of bringing the best services we can to our patients, our specialists, and just making everything better because we can, as opposed to looking at it as a fearful response that it's going to take away something from our profession.
Fully agree. I really agree what you're saying. I resonate with it as well. I think from hearing you talking, it feels like remote scanning changed your life, kind of. So do you have any advice? Do you have any advice for everyone in the room if they want to get into remote scanning? Anything that you feel like this was what made a difference for me?
And look, it really did. For me personally, the remote scanning allowed me to still support my team whilst maintaining my relationship. I didn't have to pick. If it was potentially, I would have had to have given up my relationship and just been in Queensland, because it would have felt so horrible leaving my team, or I would have had to have left my amazing job to then move to a different location and given everything up, and then been sad that I wasn't there to be able to support my team. And we're in an area that's a hard to recruit area, so we couldn't even guarantee we would be able to hire an MRI radiographer. I think anyone who wants to get into remote scanning, because it's so pioneering here in Australia in terms of we just don't have a lot of it, but I think talk to people around you, talk to vendors, see what the scope is and what the current ground is for remote scanning, and be in the know, be a part of these things that you and Julian are creating, which is talking and generating conversation. If you see an application for it within your workplace, talk to your superiors and see if there's any scope. And you don't have to go diving straight in saying we want to do remote scanning. You can dip your toe in and say that you would like a little bit more support. We want to be information sharing. We want to provide more support from seniors and juniors. A lot of us MRI radiographers have, trauma from our first solo shift on a weekend or an evening. I remember the first time I ever scanned on a weekend, my first patient was for an axillary abscess. There was no protocol. There was no one to help. It was me and an MIA on this shift, and I was like, oh my God, no one prepared me for this. I looked through our protocol and manual, and I was like, this says nothing about axillary abscesses. I don't even know what coil I use. And I'm there on my phone calling every single person on the MR list. I'm like, help me. And about 15 minutes later, one of my mates wrote back. She goes, oh, 3 planes, 3 colors. And I was like, I don't understand what that means. No one's ever said anything about 3 planes, 3 colors. But the idea that, and then panic ensues and you think, oh God, what have I done? But the benefits of this is, hey, if we have weekend services, this is how you could pose it. Why don't we have an on-call remote cockpit MRI radiographer who can assist if we need them on the weekend? And this is the operational benefit. So I think maybe it's thinking about how you're going to pose it to people as well. Like my partner referred to it as a golden square. You have your staff's wants and needs and the reality of what your staff need. You then have your operational goals and needs, and then what the operations actually need. And then central to all of that is your patient care. So I feel like for wanting to get involved into remote operations, it's thinking, how do I relate all those things back to patient care? How do I pose this as a operational benefit and a staffing benefit, and how this aligns to the goals that we have as a community in a whole? So I think it's just having open discussions and hoping that you have a manager who is open and receptive and can see the benefit. And it's dipping your toe in, not trying to do a cannonball into a pool and go full throttle for remote scanning, but more, how is the starting of this conversation, how incrementally increasing this or allowing it in. And like I said, I would pose it as we already let app specialists remote in. What's different from allowing our senior MRI radiographer to remote in when we need help with a case or something like that, especially if they work part-time. So yeah, I think it's just starting that conversation and having these conversations and being across the new technology coming out and being interested and involved is a big thing.
I think that sums up perfectly what it is. And Diogo is on the chat saying that he works in an open field scanner, and he says every day more and more he's convinced that people aren't scared of new technology, they're just scared of the unknown. And that's why we're here. That's why we're having these conversations, exactly as you were saying.
Very true.
Just start the conversation, just put it out there, just talk to people, network, and ask questions. I think the most important thing is always keep asking questions. And that's what me and Julian do all the time. We ask questions to everyone we meet about MRI. We want to learn from everyone, and that's the whole purpose of what we're doing today. Julian, do you have any questions?
Well, speaking about questions, to go through the list that is quite massive, how to say. I can see Emmanuel ask if it's possible to perform remote scans using your own computer, but I saw your little clip at the very beginning with your amazing routine. By the way, I'm very jealous that you connect from your computer, right, to assist your colleagues and everything. So that is possible, and if you want, you can perform a scan with that one as well. Is that correct? Yeah, perfect.
Correct. And my laptop is not very specky. So I bring my laptop with me everywhere because you never know when someone might need a hand. So even though I work in a hospital on site 3 days a week I work on a different MR machine 1 day a week, and then I do 2 days advanced CT. If the team need me from any of the centres, they can just give me a call. And if I'm available, let's say I've got a no-show or I've got a break or I'm on break, I just log in on my laptop and I can actually give them remote support there and then. So just because I'm not providing remote support on 2 specific days doesn't mean that I'm actually not available to my team on the other days when I'm on site and stuff like that as well.
Amazing. But he's also asking, and he's trying to put you on the spot, I think. How do you manage 2 scans at the same time? It sounds a little bit, I don't want to say controversial probably to him. Meaning that
And
I think, to be honest, in a way, when you have, you do it on site. We discussed it with Martin, I mean, last week. You do it on site at times as well, that you kind of like operating 2 scanners at the same time. It's not like a mental reality. I have to say, in UK is a little bit unusual. It can happen, but yeah, you might have to have operate 2 scanners at the same time. How do you do it remotely, routinely? How do you get used to it?
So I guess it's again a delineation between remote scanning versus remote cockpitting. So remembering I'm just cockpitting in on this plane ride. The people on site are fully trained MRI radiographers. I'm just here to help advance them. Because I've got the visibility of our booking list as well. If I know that, let's say, in the morning at our Ipswich magnet, we've got a popliteal entrapment syndrome and they're going to need me for an hour, but I know that another site might need me close to that time as well because they've got a hard scan coming up or they want to build a protocol. I can coordinate with both so that I can be fully present on one and then I just jump into the other. If there's 2 coinciding at the same time as well, I can throw additional resources at one. Typically, it's very, very uncommon for there to be 2 scans that are happening at the same time that the on-site radiographers could do without me to an extent as well. And like I said, majority of my team are cross-trained. So I will have 2 or 3 MR rads on site who are doing, they do CT, they do MR, they do general X-ray and BMD. So they're multimodality trained. So I can always go, hey, can you come and sit with so-and-so for the next 15 minutes to finish off this particular scan? I'm going to jump into this other magnet. But typically, that's just logistics of booking.
Yeah, exactly.
What you can do if you really wanted to is you could just set up a booking schedule and you could say, guys, I'm available for these 8 hours on this day. Book me in on a Teams call. Whoever's booked me in on that block is the person who gets me for that time.
Wow.
So you can put the ownership back then onto the sites to have advanced planning, look at your schedule, and then book things that they need you for around a schedule of when you're available or not. So I think that's more like a logistics thing and thinking outside the box as well. But yeah, so the scanning that I'm doing is, again, the cockpitting. I'm not doing the remote scanning where I'm fully responsible for the person on the table and I have a patient manager on site who couldn't do the scan without me. I know that America has some legislation that's come out that said we recommend against anything more than 2 or 3 scanners at the same time Australia doesn't have any of that just yet in writing, but I would tend to agree if you're expected to be fully responsible for the person on the table and you're scanning, probably don't try to multitask. Try to focus on the one patient that's kind of there available in front of you, would be my position on it at the moment.
I have to say, this thing of the remote scanning supervisor literally like fascinate me. The more you're speaking about it, and the more okay, I need to be there.
Are you getting excited, Julian? Are you
Yeah,
thinking,
absolutely.
am I scanning Australia? I might give it another go.
No, for
We'll
me,
take you.
unfortunately, now I'm caught up with Samuel and everything, MRI. No, unfortunately.
Let you go. I'll let
Sorry,
you go.
Sam, I'm not trying to steal him.
Uh, anyway, I got also Anton who tried to put you on the spot, and he say, "How is data protection ensured when you work from home?" This is quite an interesting thing because if you need to imagine like you scanning from a laptop by yourself with your Wi-Fi connection. I don't know, like I'm not a huge expert, but I could see like as a non-expert some potential threat on that.
Yeah, there is actually policies and legislation in place for data protection as well in Australia. So if you're doing any remote work at all, so let's say even as an imaging manager, you work 1 day a week at home doing paperwork, you still have to be on like an encrypted network. You can't be on an open network that doesn't have a password associated with it. I also have to go through a verification process every time I log into my computer to get onto the network for my workplace. So the cockpit setup and the 𝐸𝐸xpert is linked to my work computer network. So I can't access it on any computer. It has to be specifically my work computer. And I have to go through 3 steps of verification just to get onto my laptop. And then, like I said, I can't be on any open networks. My computer won't allow me to connect to any open internet sources that don't have a password or an encryption. And that relogging in status will force me every 24 hours to relog back in. So that's all locked down. And I've actually asked the vendors about this as well, because I said, what's the chance that someone could hack into my connection to the magnet and take control of it? It could happen. But they've all assured me that it is a closed network connection and it would be really difficult. Like someone would have to be very motivated and they'd have to bypass a lot of firewalls and a lot of things that have already been put into place. So I think even the vendors are quite aware that hacking into a signal connection while someone is scanning remotely is a possibility. And I think they've already kind of established they need to make things quite secure to ensure that no one can just hack in and take control of an MR scanner remotely, and that kind of stuff. And I think that's also a real benefit of ensuring that you have 2 points of communication. So I don't just talk to my staff through the MRI application. I also have a Teams call going at all times with a video link as well. And I have that set up in my background too. So I'm talking to them on a video link through a separate application, whilst also being able to see my team on the pit as well. So I think maybe having 2 points of anchored and tethered communication is really important too. Because then if something starts going wrong, I can say, guys, my thing isn't responding. I need you to stop and get the patient off the table. And we're not reliant on having to communicate that through the app. I'm communicating that through a completely separate application that isn't linked. So possibly something like that, like a fail-safe of communication at all time with the team on the ground is a really important factor to consider too.
And Zoe, most of the platforms actually, like the one you use, they run on cloud. So you're basically scanning inside the hospital's network itself. That's why you have to do those 3 authentications, because it's kind of a VPN. So you get in their network at the hospital, you're not using your home network. So you're getting into theirs, and then it's all based in the cloud. I don't know if anyone knows about crypto and Bitcoin, for example, but it's basically the same thing. Because it's hosted in many different computers, it's not possible to actually hack all of them at the same time to have access to that point where they're all merged in. So it's basically the same. It's not the same thing, but it's the same rationale. But that's why most of these platforms are cloud-based, because the cloud is a lot of servers, a lot of computers, putting all the power together into one place. So in order to hack this, you have to hack all of them to be able to access it. So that's more or less how your platform works, and others that I am aware of work. That's the point in terms of data protection.
Yeah, and I was going to say as well, the platforms automatically have built into them an inactivity function too. So if I'm not actively clicking within the screen, it will kick me out of the scanner, and then I need to discuss with the on-site radiographer to re-give me the access key, which changes every single time. So there is additional points of verification as well, just to be able to get in the MR scanner to be able to do the assisting role. And then there's fail-safes in there that if I am inactive or if there's the connection in the data or something like that isn't stable, it will boot me out. So there is some backups into there that if something were to happen in the background, let's say like I had an event at home and I had a cardiac arrest and I passed out. There's no one here. I'm working on my own. And then I became unresponsive. The system won't go, oh, yes, you can keep scanning and stuff. It would go, actually, we haven't had a click from you. Are you like, it'll prompt you and be like, you're going to get disconnected. Are you okay? And I guess that's, again, tying into the 2 points of communication as well, not just relying on the app on the laptop. It's having a second point of tether to the person on site so that you do have that safety component there too.
Absolutely. As I said on the first webinar, when you buy a house, it's all about location, location, location. Remote scanning is all about communication, communication, communication. So I agree 100%.
Completely agree.
Julian, do you have any other questions?
No, I just want to thank Zoe first thing, because again, it sounds like a very relatable conversation. So I think thank you also for sharing your personal perspective, and I think that is the type of conversation that I really wanted, also to put in someone else's shoes, but someone is already doing. And second thing, like one thing that hasn't been done too much, I think I want to say thank you to Samuel, because he's the one who put together this webinar series. And so without him, I think it wouldn't be possible, to be honest, to be here and to learn a little bit more about remote scanning. So it sounds a little bit a kiss situation, but it's very true. I mean, without him, it wouldn't be possible to be here talk about remote scanning. And I've seen actually an article back home in Italy talking about Samuel Oliveira discussing bringing remote scanning to the people. So I think that was quite exciting. So thank you so much for this, Samuel. And yeah, the recordings will be available for those that haven't had the chance to see it today. So I'm looking forward to see the next episode.
Zoe, I want to thank you, first of all, for being here in the middle of the night for you. I think it's awesome. And the passion there you have, it's mind-blowing. It resonates with me and Julian quite a lot. And I want to thank everyone else. They're here. They've probably been in other episodes. They're here today, and we have the next one. I know Pete is in attendance today. So Pete, you're next on the line. I'm really excited to talk to you as well. So Pete is the one of the co-founders of 𝐴lpha-RT, which is an amazing company in the United States, and they're doing a lot of work to bring remote operations to the whole country. So we're shifting gears. We've been in Germany, Europe, went to Australia with Zoe. Next, we're going to United States with Pete. So we kind of going around the world to see what's going on in the remote operations scene. So yeah, if you want to be part of that conversation as well, just take a picture of the QR codes, and that's it. We'll be together again next Tuesday. I'm not sure what time will be for Pete, but I have to stop doing this to our guests where they does at crazy times because it's not fair on them. And again, Julian, thank you so much for everything as usual. Zoe, thank you, and thank you every one of you for being here tonight and for engaging with the guests and with us. Pete is saying it's going to be 3 p.m. for him, so
That's fine. I think better than 5 a.m. for Zoe, to be honest. I would prefer 3 p.m. to be honest.
All right, guys, thank you so much for everything, and we'll see you next Tuesday, I hope. And Julian, please don't run to Australia.
No, I have to say I'm very pleased to be stuck here with you.
Guys, thank you very much, and see you.
Bye.
Thank you. Bye-bye.
Bye.